Our final speaker on the panel is Dr. Paul Moore, who's a professor at the University of Pittsburgh School of Dentistry. Dental medicine, excuse me.
Well, it's not that button. How about the big green button? There you go. My name is Paul Moore. Among other things, I am a dentist. I am a pharmacologist. I've worked out of a chronic pain clinic, and I'm a dental anesthesiologist. Most of my career has been doing research, and I thought I'd be a pharmacologist here for a moment. When I was a boy, back in the 70s, there were 3 analgesics. There was aspirin, there was acetaminophen, and there were opioids, usually codeine or oxycodone. And comes Bill Beaver, who does one of the first studies in the dental pain model, third molar extraction model, does this study where at time 0 patients have had their wisdom teeth taken out. They are now, the local anesthesia has worn off. They're at a certain level of pain, and we're going to give them either placebo or oxycodone or acetaminophen. You can see acetaminophen, even at 500 milligrams, works a little better than straight oxycodone. And then he demonstrates this wonderful thing that if you put those 2 together, you have an additive effect. And so this is the classic synergy of taking 2 analgesics of different modes of action and adding them together. That's 1970 pharmacology, 1980. Pretty impressive. And all of my professors taught me how to use Percocets. There it is. That's why we do that. But that was before we got ibuprofen. Ibuprofen didn't come along as a analgesic till late in the 70s and the 80s. And what we found out is ibuprofen works really well, and it works really well in dental pain because most dental pains are inflammatory of origin. And so it took a long time for people to start to realize that ibuprofen works very well. And this is now a study that was done by Mellish, and he's going to look at placebo, the lowest line, Tylenol, and ibuprofen. Ibuprofen is the black squares, and he's going to do another clever thing. What he's going to do is combine Tylenol with ibuprofen. And then, so if you look at the most effective line here, you're looking at a combination of 2 ibuprofen and 2 extra strength Tylenol. A pretty impressive synergistic effect. And so what we're teaching today is, and I think the dental community, who is a reasonably conservative community, the realization that we don't really need to, right off the bat, prescribe oxycodones with Tylenol. Percocet is no longer the best analgesic. And this is a study this is data that comes out of the Cochrane database. And the Cochrane database looks at 460 clinical trials of third molar extraction. 460 clinical trials, and establishes a statistic that's called an NNT. But if you notice, the NNTs, which is the number needed to treat to get one person to get pain relief, have different numbers. So if you look at 1 Advil, second from the bottom, or 2 regular strength paracetamol, the NNT is 4 point something, 5 maybe. And you can see as we go down that line, we come up with more and more effective analgesics, specifically ibuprofen, 200 milligrams combined with paracetamol, 500 milligrams. It is amazing that now we're in this world where we're worried about oxycodone, Percocet use, Vicodin use, when in fact we have pretty good agents that are not narcotics, that are not getting us involved in an opioid crisis. And we have pretty good data. 460 clinical trials involving more than 58,000 patients. That is one hell of a big meta-analysis, I will tell you. It's very impressive. If you look at what we do in dentistry, you can look at the bottom line, which says when you take out tooth extractions, we provide a 2, 3, 4-day supply, coming to something like 100 to 120 milliequivalents of morphine. and our refill rate is pretty low. Request for more opioids is pretty low, 9.3% refill rate, compared to hip replacements, where the day supply is more like 7, the milliequivalents is more like 500, and the refill rate is 32. So in dentistry, we've come up with new strategies propagated by the American Dental Association and others that suggest that opioids should not be the first line for opioid for management of acute pain. We certainly don't use opioids for chronic pain. We certainly have a problem with acute infections, and I think that has more to do with access than anything. But in terms of our procedures, bony tooth extractions, endodontic procedures, erupted tooth extractions, periodontal surgery, implant surgery, our approach now is to consider non-steroidals or alone or in combination with acetaminophen as our first-line analgesia. That's a policy statement from the ADA. And rely on opioid-sparing therapies. I think we'll all agree to that. And that if opioids are needed, they're usually needed when there's either a complication or a surgery that took 3 times as long as it should have, or something extraordinary has happened. Thank you.